Good afternoon, everybody, and welcome to Grand Rounds. My name's Tom Forden, and I'm the chair of Grand Rounds. Welcome back to what I've laughably called the summer semester, although the big flaming ball of light in the sky does suggest it might be turning towards spring. The lateness of the spring is not all bad news. It's very good for apples, so you can expect a bumper crop of apples later in the year with a late spring. The programme, which hopefully you all received by email, is for this semester is fantastic. We've got a whole heap of external speakers, which always brings I think is more interesting talks. Not that our local experts aren't fascinating, but to have an external viewpoint on things is always very valuable. And I find these external speakers by searching around corners of the internet, but mainly by recommendations. And Dr. Alan Carson, who's a reader in Neuropsychiatry in Edinburgh, with a specialist interest in head injury and the rehabilitation of these patients, gave a talk recently at a national meeting, and then a day later I was inundated with 3 emails from colleagues suggesting that we invite him up to Grand Rounds to give this fascinating talk. I know not very much about this at all. It is way outside the thoracic cavity, so outside my wheelhouse, but those are perhaps the most interesting of the Grand Rounds, the ones where we learn something about something we're really not familiar with. So I'm very pleased to welcome Alan Carson, all the way from Edinburgh, who's going to talk to us about why Scotland can't afford its current approach to rehabilitation.
Thank you very much for the invite, so no pressure there then. Apologies to anyone from a neurology background who came thinking they were going to get my usual stuff about functional disorders and Bayesian neuroscience, etc. But this is my secret day jobs, actually being a neuro rehab clinician in Edinburgh, and I'm the clinical lead of the National Brain Injury Network. And we've been trying over the last 4 to 5 years in particular to substantially alter how we do brain injury care in Scotland, because Scotland has some of the poorest outcomes in the world, or certainly in the developed world, for brain injury care, and that is a real pity, and I'll try to go into some of the reasons of why that might be. It's not all to do with services. Some of it's to do with our uniquely unfortunate relationship with alcohol, although I should give a conflict of interest of having a large wine cellar under my floorboard in that regard, lest I seem holier than thou. But these are part of the problems. So why should we be interested in it? Well, the reality is that brain injury care is the single most expensive health experience that faces the world. In terms of world global productivity, $1 in every 200 that is made gets spent on the care of brain-injured patients. It outstrips every other health condition. And yet in no NHS boards in Britain do we systematically plan for brain injury care or indeed have proper, fully identified pathways. I always like to start things with patients.
Fuzziness in the head, pain in the left eye, I stand up and simply have a sense of dizziness, feels a bit of jet lag, or dare I say a hangover. But my memory seems to be coming back. The only memories I don't have are from the time of the accident right up to leaving the Wishes at the hospital. But the family can do it.
And can you tell us a little bit about what it was like during these first 4 weeks at the hospital, as a memory of the sort of problems you had then?
It was quite frustrating because we were trying to do something for the job with his memory. He was very confused. Thought it was amazing. I thought it was new, but missing one for weeks and weeks.
So I hope you could hear that okay. This is a fairly typical case of closed head injury. It's the sort of thing that's going to be coming into your major trauma centres when you open them. So it's a guy who's at a sales convention. He fell down a flight of stairs and essentially he was knocked unconscious, degree of internal bleeding, brain edema. He was admitted to neurosurgery, originally in Poland where the accident happened, then after stabilisation transferred to the Queen Elizabeth in Glasgow. And as you could hear him saying, I mean, he just basically has a post-traumatic amnesia of 4 weeks, 4-week gap missing, during which he was disorientated, unaware of where he was, thought he was in Oban, thought he was in Edinburgh, whatever. And since then, he has still got quite significant memory deficits. He's talking about getting back to work in this video in a couple of months' time. It's highly unlikely he will return to work. His odds are about 10% given the population he comes from. So he's going to go from being a higher rate taxpayer to a tax consumer. He has problems with his balance, with irritability and with dizziness as some major connections. And this is not a particularly severe case. This is kind of fairly run-of-the-mill head injury stuff. And typically after head injury, people will have problems with their cognition, they'll have problems with their mobility, they'll have problems with movement, with emotions. And the time I was writing this, I just went through my ward. I had patients with swallowing deficits, a range of aphasias and dysphasias, quite a lot of high-level balance disorder, visual processing problems. It's not that people are blind, it's just that they can't actually sort of make out where they are in relation to space for doing things like climbing stairs. Cortical blindness, though, does occur. We had one patient with that. Cortical deafness occurs. Epilepsy is commonplace. Spasticity, Parkinsonism, paresis to varying degrees, anosmia, psychosis. This sort of fairly typical constellation of problems, which I think is pretty self-evident would be highly disabling. So how much of this is going on? Well, we'll have about 2,000 presentations to the emergency department in Edinburgh each year, of which only a small minority will have overt lesions on CT. We probably over-admit in Edinburgh for observation, and only about 1% go on to neurosurgery. So the first thing, if you're not a head injury expert, is to realise is what a minor proportion of people actually need opened up. Most of the care is within crit care sort of domains and within stabilisation, trying to maintain intracranial pressure at a lower level and observation. What you're looking to do is to catch that very small proportion of people who have expanding lesions in their skull that are going to go on to be fatal. It's a minority, but it's not always straightforward to find them. And these rates are roughly the same in Glasgow. So if you're trying to calculate in terms of your MTC project how many severe head injury patients you have, that seems to be a reasonable guideline, and you can probably make a straightforward extrapolation from the population you're serving of how many patients will be coming through. This translates to about 650 to 700 severe head injury cases per year in Scotland. Average age of injury is around 38, and the population life expectancy, if you weight it towards deprived populations, and head injury does tend to occur more commonly in deprived populations, is about 73, a reduction in life expectancy of 5 years. So we're going to have a life expectancy post-injury of around 30 years. If patients are identified, they're typically stable from severe injury within about 3 weeks, but transfer to rehabilitation, if it happens at around 6 weeks, and thereafter people need about 75 days worth of neuro-rehabilitation. The variation in length of stay in South East Scotland, so that's between Edinburgh, Forth Valley and Fife, is only 2 days. And it's almost identical St George's in London, Nottingham and Salford, and every other major trauma centre you go to. So in planning terms, you're kind of looking at that's what you're going to have to provide. But remember, only 10% of head injuries get managed in a neuroscience centre. So this is our most disabling condition we face in the UK today in the under 65s. It's life-changing, and yet the majority of people don't see anyone trained above the neck, which is slightly worrying. Most significant head injuries in Scotland still don't get any rehabilitation of any type. When it's been audited in Scotland before, it can be as low as 25%. So it's not a good picture. How much does this cost us? And this is where the main meat of things are. If you're looking at the annual care costs of patients with severe disabilities, so that roughly speaking equates to severe head injury. This is from NICE's Health Economics, so they're relatively reliable as far as health economics ever is. If anyone gets involved in clinical trials, you know there's an element of putting your finger in the air and sticking it up. It's about £45,000 per year for direct care. That's not excluding loss of contribution to the exchequer by not paying tax. So if we want to quickly calculate it, that's 650 patients per year, 45 grand each. We're up at 29 million for a year. So we're spending big bucks on doing this. And if we want to take it over the 30 years, discounting the fact that about 15% of patients in Scotland actually have a better outcome, so they're not severely disabled of this group, we're up at 739 million. This is what we spend a lot of money on. And when you go to planners and you talk about healthcare spending, everyone is obsessed about the ageing population. But actually, the care costs of the ageing population are not going up as fast as people anecdotally think. In fact, they're relatively flat. What is happening is that people are attracting these care costs at an older age. So I was on the phone to my old man just before coming here. He's just come back from the Pyrenees where he's been mountain biking. He's 80 years old. He and my mum drove themselves down, drove themselves back. Dad still actually works half-time. He pays higher rate tax. So he's actually a net contributor. He tracks no care whatsoever. Now, sometime, given that he's 80 over the next decade, he's probably going to start taking tax out of the system in terms of that. But actually it's not. What's happened is it's upwardly shifted. The big hit is with pensions. You know, whoever the actuary is who calculated his pension, banking on him dying at 74, is looking at being 15 years over time and absolutely stuffed. So that's where the money's coming out the system with the elderly population. It's not actually in terms of care as people think. Where the care system is getting stuffed is with the below 65s. They are rising exponentially and in the next 5 years will overtake the over 65s in terms of care costs to our society. And we really do not plan for this group at all. You go to meetings, it's all about Alzheimer's care. In fact, it's relatively straightforward. People need relatively straightforward nursing home placements, and I don't want to sound blasé about it. My mother-in-law, who I'm very fond of, is in a nursing home with Alzheimer's at the moment, but she is going to die in the next couple of years, and that's the reality of it. Whereas these people post-head injury, have got 30 years of life expectancy minimum within them and increasing expectations. So just be aware of the costs involved, and anything we can do that minimises care costs is going to have a dramatic effect financially. And that's where my interest in terms of rehabilitation comes into all this. It's worth saying from the outset that rehabilitation is not all the same thing any more than surgery is. What the procedure is and who does it makes a difference. And we can think in terms of evidencing this in terms of individual techniques. We can think of the biological underpinnings in neural terms, or we can think of some systems of care delivery. And there's a surprisingly large amount of evidence to guide us. We've got sign guidelines. We've got the World Health Organization's guidance to trauma care. Cochrane. One of the few things that Cochrane actually makes a statement on, saying we know what works. They don't even say the usual of we need more trials. We've got English commissioning guidelines in rehabilitation, a lot of experience in that way, and we've got NICE's guidelines on head injury. And for some reason, certainly in South East Scotland, all the planners just believe that it has to be Scandinavian to be any good. There's also the Danish health technology assessments. I'm going to spare you the minutiae of these. What you get is a very consistent picture. The early, intensive, specialist, multidisciplinary, team-based rehabilitation is what pays the money. It works. And none of that should really be a surprise. Why does it need to be early? This is some data from one of my friends, Nick Ward, at Queen's Square. And what we're looking at is what happens in terms of brain reorganization. I'm going to use stroke as a model. It's exactly the same process neurologically, but it's just cleaner to see in imaging. And we've got cases A and B. They're both cerebral infarcts. They're both causing contralateral hemiparesis. And this is what happens over the first 3 months in terms of neural reorganization. What you can see is our brain is a plastic organ that responds to damage by living cells and networks taking up the task. The key issue is that it does most of that in the first month, and that can happen both ipsilaterally and contralaterally. So things like speech and language can move from dominant hemisphere to non-dominant hemisphere in such circumstances. But it happens early. Typically, in terms of our clinical care during that period, that's a period where we're just leaving somebody lying in a bed and not doing much. We're not training them. If we want to promote recovery, we have to ask the question, does recovery depend on plasticity? And by plasticity, we're meaning cortical changes where the strength of existing connections, in other words, synaptic connections are altering, new synaptic connections are being made, but also we're getting rid of redundant connections to create new networks. It's particularly affecting in motor function the pyramidal cells. And what we find is that the earlier you intervene, the better the outcome. So if we're looking at the graph on this side, so that's the left-hand side for anyone in Perth, you can see where the red arrow is. That's when you go in at day 1 and start rehabilitating an artificially lesioned mouse. If you leave it for 4 days in mouse terms, you start to instantly have a knockoff, and if you leave it for, I think it's 14 days, you don't have any impact at all. And the degree to which the mouse improves correlates entirely with the number of new branches and the complexity of layer 5 neurons in the pyramidal cells. In other words, you are rewiring the brain by coming in early and rehabilitating early. And this is a time-limited period. And the questions really are is how to take advantage of this critical period through optimal timing, intensity, amount, and even type of behavioural training that makes up neurorehabilitation. And the era we're moving into over the next decade is how can we augment that natural biological mechanism of post-injury plasticity to enhance or prolong the effects of behavioural training. In other words, if we can double that plasticity window, we may theoretically double the improvement of outcome. The biggest model most of you will have had of this in your own lifetime is bringing up children. Children's brains are incredibly plastic. What we're doing in terms of their upbringing is just what you do in neurorehabilitation. You're teaching the brain to interact with the environment and with the body to build and work out. And for people of my age who can remember the Romanian orphanage scandal where children were just left in a cot until age 8 with no interaction, so no training, it has a dramatic effect on neural development. It was hideous seeing the scenes of just how mentally disabled these children were. But essentially that is what we do clinically. We put somebody in a bed and we leave them for several months. What can we do to enhance it? Can we manipulate plasticity? And this is going to be the sort of direction of the future. Now this is a slightly complicated graph, but I'm just going to go through it quite slowly. So we're going to start on the top left, and we're looking at a lesion, and we're looking at rehabilitating from day 1, and we get back to near normal function. It's quite straightforward. We do exactly the same rehabilitation, and this is going down to bottom left now, but we wait 7 days, we get no improvement at all. It has no impact. In other words, we've missed that critical plasticity window in the mouse, and all the rehab we throw at it makes no difference. If you're trying to see the lines, the rehab lines, the bottom one, it's sham, i.e. non-lesion people are on the top. However, if we go to the same mouse, we lesion them, and from day 1 we give them fluoxetine, which, although you probably know is an antidepressant, also seems to have the property of opening and delaying the closing of the plasticity window, and then we start the rehab after 7 days, we get exactly the same outcome. In other words, we can manipulate that therapeutic window. But if, and we're now on bottom right, we wait 7 days before giving the fluoxetine, the window's already shut and there is no improvement. So this is kind of where the future is going to lie. Is A, optimizing the training you give during plasticity windows, but also therapeutically manipulating the window to give a chance for these things to happen over a longer period of time. But plasticity doesn't just apply to injury, but to new adaptation. And when we're thinking of how our brains interact with the world, we've got a combination of what in neuroscience terms we call top-down changes. In other words, that's your cognitive structure that gives you a clue of how to interact. So as I look at this lectern, I have already got pre-existing ideas of what it's going to weigh, what it's going to be like, what it's going to feel like. But I'm also trying to integrate that with what's coming up in what's called a bottom-up way from my senses. And what your brain likes is when these things match. So if you remember the video of the chap at the beginning, he was complaining that one of his current problems was of subjective dizziness. Now I can tell you, if you examine him, he doesn't have any nystagmus or anything, he just has this feeling that he can't interact with the environment normally. And what you're getting in these situations is a sort of Bayesian idea of how the brain works on prediction. You've got a whole load of currents from your ears, your eyes, and your legs, and you've got an expectation of what you think they're going to say. And as long as they match up, your brain's quite happy about it. But if they don't match up, it feels it's unpleasant and starts to get dizzy. This is no different to running your household. If my wife and I both think it's my turn to do the dishes, everything works quite happily. As soon as one of us thinks it's one person's turn and the other thinks it's the other's, that's when the problems start. And that is all you need to know about Bayesian inference in neuroscience terms. It's the same kind of idea. But what is important, it's not just the top-down expectation, that matching up that matters, but it's how we behave in response alters. And this is taking people who have a worry about being dizzy and putting them in a high-risk situation, i.e. you stand them on a balcony and get them to look out at the view. So if I take you to that beautiful new gallery you've got down on the shore in Dundee and get you to look out over the Tay from one of the balconies, you'll probably look around, you'll take in the surroundings, it's very beautiful. But if you're dizzy, you will go rigid and you will stare fixedly ahead. And that's what you can see. This is what a normal subject does in terms of eye tracking. This is what a dizzy subject does. They don't move up or down. They just stare fixedly ahead. And you start to get this clustering of view if you do it over subjects. And this is the basis. It's that interaction between this altered sort of bottom-up change in behaviour and top-down expectation that creates the dizziness. And actually one of the commonest causes of dizziness, the condition that you'll all have seen in your clinical practice but probably didn't know what it was, and that's persistent postural perceptual dizziness. It's a common characteristic treatable cause. Excellent paper in practical neurology about it by one of our trainees, Stoyan Pokurov's, worth reading. But essentially why this matters is when you start to have that early on, you have functional brain changes in key areas. But they quickly become structural after 2 or 3 months because our brain modifies itself according to its environment. It's a plastic, living, moving organ. If you intervene during the very earliest stages where these are just functionally adaptive, you can treat very easily. If you wait until it's become structural, it's much harder to get the thing. So this is why we need to intervene early, partly to get adaptation to injury, but also to enhance the adaptation to new learning and complications. Why does it have to be intensive? Well, dose matters. And curious enough, we don't seem to think about that in rehabilitation terms. People say, oh, well, we can really only afford to give 1 session a week, so that's what we should do. I mean, nobody sits there in Tom's field and says, well, those antibiotic things, they work for TB, but they're quite pricey, so you can get 1 tablet a month, and we'll see how that plays out. You're like, this is the dose we need. And it's the same in rehabilitative terms. This picture is of Patricia Neal, famous actress who suffered a hemorrhagic stroke in 1965. She was aged 39 at the time, and her then husband, Roald Dahl, made the comments that surely an hour a day's rehabilitation is not enough. And he, with family members, put together a really quite gruelling rehabilitation program based on about 4 to 5 hours a day of active treatment. And she made amazing progress. She recovered back completely from a stroke that would normally have resulted in somebody being in a nursing home in that era. And she, in fact, went back to acting and, in fact, got an Oscar nomination. So we know that dose matters, and that has been trialled in umpteen studies. If you give 1 hour a day in terms of upper limb rehab, you'll get a reasonable outcome. If you go up to 2 hours, you don't quite get 100% improvement, but if you go up to 3 hours, you do get 100% improvement. And these are dramatic differences for relatively cheap interventions. But we have to have a healthcare system that can deliver that intensity and this is from my colleague Nick's own work, which just shows the same thing. You can do it really quite well. By contrast, though, what is happening in Scotland in terms of rehabilitation is we're going to generic late rehabilitation in the community, usually one therapist going out once a week. There's actually some really good trials, MRC sponsored, this is one of the better ones, that simply show doing that makes no difference whatsoever. If the intensity isn't there, and this is a typical, 4 visits once a week over a couple of months, it just doesn't make any difference. I was putting these slides together when I was filling in my tax return, and I worked out that I'd paid £1 towards that study, so it really irritates me if people don't listen to it. We're going in a direction that we know doesn't work, and we're ignoring the evidence of what does work. Why does it have to be specialist? Well, there's always going to be attention at how specialist you want to be, but essentially the eye won't see what the mind doesn't know. And this is an example from physiotherapy treatment. It's actually a slightly different field, but it just gives us an example. This is a patient who's had this gait disorder, functional neurologic gait disorder, for 6 months. He's had 7 previous courses of physiotherapy, and he was wheelchair bound. He then spent 5 days with Audrey Matthews, physio extraordinaire at Queen Elizabeth, who's very interested in this particular field of rehabilitation of functional disorders. And they got him up and moving using some rather different techniques. And what you see after 5 days is this guy's walking normally. Now that's the difference between knowing what you're doing and knowing what you're not doing, as it were. And there's always a compromise, and the smaller the centre, whatever, the more wide you need people to be able to spread their wings. But we need people who know what they're trying to treat and what the models are. So what are we currently doing in Scotland? Well, the east of Scotland has 10% of the neuro-rehab consultants of most European countries. And although I'm talking neuro-rehab consultants, you can put that for the whole rehab team, AHPs, nursing staff, etc. Rehab is a team sport. The west of Scotland has 2% of most European countries, more neuro-rehab consultants in Dar es Salaam than there are in Glasgow. We should have about 400 specialist neuro-rehab beds. We've got 140, and further reductions are suggested and planned. And as I was saying, the general move is towards delayed community rehab, low intensity, delivered by generic therapists working as individuals rather than teams. This process is being accelerated by the move to integrated joint boards, and it's the single biggest risk to the MTC plan. If you go to anyone who runs a major trauma centre anywhere in the developed world, they will tell you that closed head injury flow is critical to success. If you don't get that right, you're going nowhere. This was this couple's experience.
I have a nursing background, but the idea is for the patient to nurses, my sister also was in poor, and she was got instrumented to the fireplace. Really quiet with meditation, and we couldn't really put in meditation because it was so important. For James recovery at an early stage, we had to have meditation. I felt really quite frustrated. Quite a lot of time being booked in because they were trying to access help, and to be fair,
So this couple's a fairly typical story. They actually have finally managed, but only after 3 months post-injury, missing the biggest window of improvement, and that's tragic because it's going to miss his biggest chance of success. Now, when you present this, people say, okay, it's not great, but money's tight, and we've all got to make savings, and realise that. But we actually have quite a lot of randomised controlled trial evidence from England. I don't expect you to read these tables. They're just kind of a sort of convincer to show you the trials have been done. And they're on reasonably large samples for this type of intensive work. 3-armed studies, 100 patients per arm, etc. I appreciate it's not mega, but it's fairly robust. And also real-world efficacy studies from when MTCs came live and started doing hyperacute rehabilitation. And to save you reading the tiny print, what they say is that the consistent message is that early intensive inpatient rehab saves £30,000 per annum per patient. Now that's big bucks. Times 650 patients, that's 19 million across the year in Scotland. That almost pays for the whole MTC project. If we times that over the lifetime of the patients, that's suddenly 585 million. That is massive. Now these are optimal figures. But even if we got 25% of that, 50% of that, and given that it's based on what England actually got in the real world, there's no reason we shouldn't be aiming far higher. These are massive savings. They would more than fund the changes needed. Currently, we're trying to save money by not investing in rehab. An episode cost full inpatient stays $77,000. But you've got to remember that most of that is the cost of being in hospital. And actually, if you go through a rehab system, you're discharged earlier, not later. The excess cost to do the whole thing properly in Scotland, we calculate, would be about 8 to 9 million. So we're looking at that. We're looking at trying to make these savings. And in order to spend or to save 8 million up front, we're spending 585 million down the line. Now, even Wonga wouldn't approach that kind of stuff. And yet that is how we're actively planning our hospitals and our care systems. So what do we need to do? Well, I think it's quite straightforward. Like anything else, we need to look at the clinical trials and understand the underlying biology. We need hyperacute rehab from the day of admission, because the biology isn't going to wait around for us to plan our services. These are plasticity windows, they exist, and that's it. So what are we going to do in Lothian? We're certainly planning to have all head injuries admitted to a ward jointly run between neurosurgeons and brain injury physicians, supported by a full multidisciplinary team. I emphasise again, brain injury is a team sport. We want to have a rehabilitation pathway from the MTC to inpatient care and on to the community, and that's going to require a whole board approach. You can't leave it to a rehab directorate. Their budgets push in the opposite direction. And we need to educate our colleagues in the integrated joint boards, because they don't have the clinical or neuroscience experience of this yet. It's not a priority for them. So in summary, I think the MTC project is our biggest opportunity to solve the head injury problem that everyone's known has existed for 60 odd years. And we can do it, and I think we let down our patients, communities and taxpayer if we don't. I think this is actually an opportunity to save a lot of money for the NHS and to significantly improve patient outcome, and that doesn't come along too often. So I'll stop at that point. I hope I haven't bored you silly, and very happy to take any questions if you like.
Charge at the microphones. That's fascinating stuff, isn't it? I mean, something I have very little experience of. What's the kind of range of people you're looking after here? Clearly, this chap had regained a fair amount of function. Are you looking after people right at the very end of the spectrum who are unconscious and unconscious forever?
Yeah, I mean, at one end you will have people who are in minimally conscious states and will never recover consciousness, and their care is a separate issue. But the majority of people after severe brain injury are significantly disabled. He is significantly cognitively disabled with bitter physical problems in terms of his balance. Quite a lot of people will have some degree of paralysis, degree of epilepsy, etc. And it's enough to stop them returning to work. They need care costs, they need help and assistance. But they're not, to use a technical term, absolutely knackered. And there is room for recovery. And even in those who are really quite unwell, and I'm talking about tetraparesis with severe dementia, with rehabilitation, if you can reduce the degree of input, I mean, some of our worst patients, you're looking at nursing home costs of £350,000 per year per patient. If you can take that down to somebody managing in a normal nursing home environment of, say, 100k a year, that's still a massive cost saving, and the rehab is worthwhile. And the evidence is pretty good that you can get enough people better or significantly improved that you can make a massive difference. So your population's going to be what, about just under 1,750,000 Tayside, or is it a bit smaller than that?
A bit smaller than that, maybe 500,000, that kind of size.
Half a million. So what would you be looking at? You're looking at about 30 to 50 patients per year. So it's not massive numbers, but it's not insignificant either to hospital or bed flow.
Has anybody got any questions or comments they'd like to make? Any queries? Any comments from the major trauma people? Hang on. There you go.
Thank you very much. Just wondering if there's any application for the fluoxetine in maintaining neuroplasticity in humans. Yeah, any trials on the horizon, or is it being used already?
Yeah, so there's several trials in... So I hope I heard your question okay, but several trials in acute stroke going on, focus trials due to report later this year. They're using fluoxetine, which does seem to have some effect on humans. Whether it will be as dramatic as it is in rodents or not is open to question. I think at this stage the key issue with it really is more as a marker of a direction of travel. It signals and tells us a lot about what the biology that's happening in the brain is, and there's clear evidence that that does apply to humans. Will we be in a stage where everyone gets put on fluoxetine from day one? I suspect what we'll get is a relatively weak result from focus that suggests it's marginally helpful, and we probably will do it, but I'd probably suspect it may not be the drug, if you see what I mean. But what we are going to see is a range of attempts to therapeutically manipulate the brain's response to trauma, both in terms of plasticity and learning, and also in terms of what happens over the months in terms of the inflammatory response and to what extent that could be drug manipulated. And I think there'll be quite big sea changes in the next 2 decades, which is really the period we're planning for now. But, you know, my department is very interested in regeneration and stem cell therapies. But, of course, the thing that people don't always appreciate about that is that when these therapies come along, and I say when because I think they are coming on stream now, and I think there is no doubt they will happen, is that the brain is going to need new retraining. It's not just a case of pouring a few stem cells in the top and it'll just go back to where it came from. Your brain is going to need to be retrained in how to use these. And similarly with adaptive technology, which we're starting to see in spinal injury, of implanting EEG leads into the brain, you know, these things need training to make artificial arms and legs work. So I think it is important that we have a system that can support the trial evidence as it starts to emerge, and you know, I think we are having a sea change of how that's happening at the moment. So I think we should be planning for that development, because it is coming, and you know, I think getting it right is an important thing, and Scotland would be very well placed to lead on such trials because we've got a relatively closed population, and if we're thinking of Central Belt Tayside, we've got most of the population living within an hour's drive. There's no reason why we can't be setting up, you know, centres where we're dealing with most of the Scottish population going through the MTCs and delivering treatment trials of these drugs as they come available, and that should be one of the priorities, I think, for the MTC project. Obviously, an academic in neuroscience, I've got some conflict of interest, but you know, they can't do this sort of stuff as well in England in terms of their population, so we should be knocking on the door of the MRC for the cash.
I guess it's just a paediatric plug.
Yep.
Probably smaller numbers in absolute terms, but the impact is just as significant, if not greater, in terms of family and society.
You're missing out 2 ways. You're missing out on the developmental opportunities that you would normally expect to occur during these periods as well. So
we've got virtually no rehabilitation services for this sort of thing in paediatrics, as far as I know, that are designed in an organised fashion. It's very piecemeal and very ad hoc.
Yeah. I couldn't agree more. It's certainly something from the brain injury rehab side, or the brain injury network, we're very worried about, and we are trying to get that dialogue going and getting people to think in a much more systematic way about how they plan for that care. It is traditionally been difficult to get the people who are involved in paediatric neurorehabilitation to collaborate. They all have their own idiosyncratic views. So, for instance, I was involved in the SIGN guidelines on neuro-rehab, and paediatrics were invited, and they couldn't agree amongst themselves what the scope would be, so they disinvited themselves, which I think was a disaster. And I think it would have been better to have had a guideline that at least got the ball rolling, even if it wasn't perfect, than to have dropped off because they couldn't agree on whether it should be a clinical psychologist or a neuropsychologist or whatever, or you know. So I think, yeah, there's a lot of work to be done there, but I would fully agree it's, if anything, more important.
Yeah, Alan, Michael Johnson, I'm heavily involved with the major trauma sort of centre set up, major trauma network centre set up locally and nationally, and I think it's really interesting that when we started out on this journey, getting on for 4 or 5 years ago now, when all of us got into a room in St Andrew's House. There's undoubtedly that the emphasis there was on the front door of how we set up the services and the things that we might need to improve care. I think I'm right in saying that within a couple of years or so we recognised that in actual fact for the Scottish trauma population, whilst these things had some importance, we really were looking at what you do and what Douglas does and your other colleagues up and down the country in rehab as being the thing that's going to make the big difference, really, to the Scottish trauma population. What's your sense of getting that message across now nationally? Do you believe that you've got traction on this?
Yeah,
because
I think we do. I think like all these things, it's a bit like turning round a super tanker. You sort of start and you turn to meetings and you'd be the boring guy who would mutter about interneurons in the corner and people would roll their eyes and there's Carson, what the fuck's this all about? And will he shut up soon? And then, of course, as you know, about a year ago when the project looked a wee bit doomed financially, suddenly saying, well, actually, we could save money with this whole project, not spend it, suddenly became very interesting. And I think once people started listening, it's there. And I think, yeah, it is on the roll. And I think people do realise it's the way forward. And I think it will happen. And I think it will be one of the big successes. I mean, as you may have heard me say in the past, I drive on motorbikes. I've got a conflict of interest on major trauma acute reception. And, if I'm one of the 17 lives that get saved, I'll be well chuffed. But I think the reality is actually that the success will be judged on improved patient outcomes. And I think that's where we can make a massive difference. And although I'm talking from the point of view of head injury, I think exactly the same applies to orthopaedics. And we tend to think of orthopaedics in terms of bone healing, but actually the largest part of outcome from orthopaedic injury is to do with brain neural adaptation to that bone healing and how it responds, how pain circuits modify, how people emotionally adapt, how proprioception returns. And the same things apply. And the Army have been doing this in orthopaedics starting from day one for years now. And their outcomes are just on a different planet to the NHS. Now, they're getting young, fit soldiers, and it's not quite the same as our population. But I think a lot of it is what they're doing, and they do exactly for orthopaedics what we're proposing for brain injury. In fact, we've got Colonel John Etherington coming up to Edinburgh 4th of June to hold a one-day workshop on exactly what their model is so that we can copy that for our MTC ward. And if you or one or two of your colleagues wanted to join us for that meeting just to get a feel of where they're at, you'd be very welcome, very happy to extend that invite. But I also think it applies across the board. If you're running a respiratory unit, I think we've got a little bit too divorced between the drugs and the therapeutics and the therapies. And I think we should think of hospital. I mean, when I go to planners, people think admitting people to hospital is a disaster. I think it's a therapeutic opportunity to try and sort things out. And I think being much more active about what we do with patients in hospital when we've got them under our eye applies across a whole range of specialties, not just in trauma cases. But I'm kind of hoping trauma, if we make a success of it, will actually show that. And perhaps help us realise some of the things we've lost as we've developed more effective biomedical therapeutics. And I don't think these things are either or. I want both if I'm ill. I want the whole lot. I want a physiotherapist treating my asthma on day one. I don't want to wait for ages, and I want it to be intensive. But I also want the sort of stuff that somebody who understands a bit about lungs and inflammation is going to do for me as well. And yeah, I just kind of think it's self-evident, really.
You're right, incidentally. If you do come into the chest ward, you want physio from day one. It's there's evidence for that is building rapidly.
Yeah.
Okay, anyone's got any other questions, comments? Otherwise, I'll wrap things up. I think it's a fascinating talk. Thanks very much for coming. Thanks very much to Alan Carson for making his way up the M90 to give the talk. Next week, Ellis Friedman is coming up from London. He was the Director of Public Health in the West Pennine area when Harold Shipman was at work, let's say. And he led the investigation into the outcomes of Harold Shipman's patients and was instrumental in the court case that led to his incarceration and ultimate suicide. Ellis is going to come to talk about Harold Shipman, my part in his downfall. It's going to be absolutely fascinating. I really encourage you to come along and bring a friend, because that's a rare opportunity to hear from someone who was really intimately involved in what has been described as the biggest serial killer in the UK history. So please come along to that, and a big thanks to Alan Carson for a fascinating talk. Thanks very much.
Come back next week.